and Maureen Boyd are GP representatives for the Shared Care Committee at the Hospital for Women. So first I'd like to acknowledge the Aboriginal and Torres Strait Islander peoples of the Darawal, Gadigal, Warrigal, Gwanggal and Bidjigal peoples as the traditional custodians of the lands we operate on. We pay our respects to ancestors and elders, past and present, and SES LHD is committed to honouring Aboriginal and Torres Strait Islander peoples' unique cultural and spiritual relationships with the land, waters and seas, and their rich contribution to society. Do you want to, shall we pause for a second? Just. That's okay. Right. That's okay. Maureen will get some things to help clean up. Maureen's gone to get some things to help clean up. That's fine. We'll keep going. So this is a picture of the original Royal Hospital for Women site in Paddington. I mean, prior to that, there was a the first lying-in hospital in New South Wales set up by the Benevolent Society in 1866. And then in 1905, the site in Paddington opened. And it was transferred here in 1992. And there's a picture of that's the operating theatre in around 1912 and one of the wards around the same time. And the first antenatal clinic started in 1912, and it's actually the longest running antenatal clinic in the world. So with today, a lot of the important things with the shared care program is who to contact and to know that there are people that want to help you. If you have any questions, you're not sure what to do with a patient, that there's people who can help. So the unit manager, midwifery unit manager is Meg O'Neill. And we've got Chantel and Hui-Ling. Is she here? She'll be around a bit later. Yeah, she's here. You can meet her. So they're really important. They're the shared care liaison midwives, and their number is in the pack. So if you have any questions, you're not sure about a patient, you want to do an urgent referral, you're not sure how to do that, or which clinic to refer to, then Chantel and Wei-Ling are the people that you would call. There's also obstetricians associated with the program, and we've got Dr. Alex Owen here today who's going to answer a lot of questions for us. And then there's GP representatives, and from the committee, Maureen and I are here today. That it is, that's right. And then the PHN also are very helpful, and we've got Wayne in here, and Lauren Thomas is online. So I think you've got a copy of the current shared care guidelines. They are under review at the moment, and the schedule of visits is changing a bit. So this is going to change. It's not going to change drastically, but there will be a few minor changes, and that's probably going to come through early next year. So keep an eye, you'll get emails about that from Assessment. But for now, refer to that protocol, and it's got all the phone numbers. So down here, so it's got all the phone numbers of people that you need. That's going to stay the same. That's really important. And it's got all the things that you need to do at the different appointments. And we're going to go through all that today. So at the Women's Hospital, there's different models of care. So there's a shared care model, which you're participating in, and that's shared with a midwife. It's generally for women with a low-risk pregnancy. They may see a specialist if required and stay within the shared care program. If they're deemed high risk, then the model of care will change. There's also the midwifery group practice, where there's an assigned midwife throughout their antenatal and postnatal and intrapartum care. So that midwife is on call. Home birth is available in that option, and it covers all risks. So there's options even if the woman is a high risk patient. Within that, there's the Malabar MGP for care for First Nations people and the maternal-fetal medicine MGP, so that's for women with complex needs. Then there's the MAPS where they do antenatal and postnatal care. Again, it's midwife service. There's a small group of midwives. They provide intrapartum care by general birth unit staff. Again, it's an all-risk model, and then women can always choose to see a private obstetrician throughout. Some private obstetricians do shared care with GPs as well. That's up to you and the patient and the obstetrician. So then there's these specialist pregnancy clinics, which women you may refer to initially, or during their pregnancy, they may get changed over to some of these clinics. So if women are high risk for various things, and there's lots of clinics. So if they've got twins, if they've had preterm birth or they're at risk of preterm birth, infectious diseases, if they get diabetes or if they've got diabetes, if they have things like underlying cardiac condition, renal, cancers. So there's lots of reasons that women will get referred to these clinics. You can do the referral yourself. You can call the liaison midwife if you're not sure where someone should go. So ideally, you want to see women before they're pregnant and checking in particular folic acid before they're pregnant. And iodine, I guess you can start when they're pregnant. Remember that some women have increased folic acid needs, for example, if they have a high BMI. Doing the genetic carrier screening. So I guess there's that free triple test now that every woman can access once in her life that you get a Medicare rebate for the cystic fibrosis, spinal muscular atrophy and Fragile X. And then thalassemia is commonly tested as well. Again, they only need it done once ever. If there's a positive result, then they should get their partner tested. And for that triple test as well, there's a Medicare rebate for the partner if they test positive. It's good if they have their cervical screening test up to date. They've had all their vaccinations done, so particularly things like measles, mumps, rubella, chickenpox, because they're good to get done preconceptually and to wait 4 weeks before they conceive. And then what are they doing in their life? Are they smoking? How much are they drinking? What kind of exercise? What's their diet like? There is a free New South Wales health service called Get Healthy in Pregnancy. The woman can self-refer, you can call or register online, and they've kind of got a health coach who calls them and talks through things, so that can be helpful for some women too. They might want to do some cycle tracking or at least be a bit conscious or use apps to track their cycle and start getting an idea of when they might be ovulating. And it's good to get the partner involved. So sperm should be healthy too, not just mum. So if you do identify a woman that she has complex needs, again, if she has existing cardiac, renal conditions, any previous or active cancers, there's a long list of things, then sometimes there's a preconception clinic that exists at the hospital that you can refer to that can help with that journey even before they get pregnant to make sure that everything's going fine. So, early pregnancy appointments, you'd hope that they're going to come in quite early. Often they'll book it as a 15-minute consult and there's a whole lot of stuff to get through, so prioritising is really important. So it's good to ask if it's a wanted pregnancy or not before you start launching into their pregnancy care. And to determine the estimated due date, so there is, in the clinical business rules for the hospital, there's guidelines on the estimated due date. The best practice, the one that's linked in with best practice, really correlates with that, and I tend to use that. So think about doing a dating ultrasound. If a lot of women like having it done, but particularly if they're unsure about their dates, then that's really useful. And just to see how they're feeling. Are they tired? Tiredness is so common in pregnancy. Nausea, again, very common. Breast tenderness. These things usually resolve after the first trimester. So just discussing those things, and if they are having really troublesome symptoms. And then the routine investigations as per the protocol, which are, so there's blood tests and a urine, basically. So full blood count, blood group and antibody. So if these things like rubella haven't been done, then make sure that you do rubella, chickenpox maybe. And then these other screens, Hep B, Hep C, syphilis. You do that twice in pregnancy, the first time's now. HIV, do an MSU. The syphilis will be done again at between 26 and 28 weeks. You might want to do some other things. So the cervical screening, if it's due. Ferritin, if they've had a low iron, a lot of women, there's a bigger demand on iron during pregnancy. That's a good one to check before they conceive, if possible, so you can get their iron up, because it can be a bit harder to tolerate iron supplements early in pregnancy. But checking their iron, chlamydia, if they've had STIs in the past, or if they're under 30, or you think that they're at high risk. Considering thyroid function and the thalassemia if it hasn't been done, and then potentially a dating ultrasound. Then, so there's a whole lot of other things that you can discuss, including their lifestyle. You can do the Get Healthy in Pregnancy referral. Have they done the folic acid? Are they taking iodine? And then all the food rules, the pet safety. Do they have a cat? Who's changing the kitty litter? Talking about, I guess, infective disease risk generally, specifically for CMV, but that's a bit of a tricky one. COVID and influenza risk reduction. So that just depends on what their life looks like. So if they're working in a childcare centre, that's a pretty hard one to minimise their risk of viral infections, but it's something to flag and that they should be conscious of. And if they do develop symptoms and particular rashes, then just that they come in. Vaccinations are important during pregnancy. So influenza, you can have it any time. And it's certainly recommended for every pregnant woman. The Boostrix or the pertussis vaccine is recommended between 20 to 32 weeks for every woman in every pregnancy. COVID-19 vaccination, it's a bit not as strongly recommended as it was in the past. Rubella, don't give it while they're pregnant, but they should get it after they've delivered if they're not identified as not being immune during pregnancy. Some women do need low-dose aspirin. If they're at risk of fetal growth restriction, there's the Safer Baby Bundle, which we might talk about a bit later. And then you can maybe flag at some point the first trimester screening options being the combined first trimester screening or the non-invasive prenatal testing and early structural scan. So that's a lot in 15 minutes. That's not really going to... So, yeah.
Sorry, just with the need for aspirin, I've noticed that some centres like ultrasound care, they'll do with first trimester screening, they'll actually assess sometimes the need for aspirin, whereas other centres of those just don't. So is that, would you recommend, like I tend to refer to ultrasound care into the spectrum of symptoms?
Yeah.
But there's obviously a wide variation of it. So what would you recommend for you?
So, yeah, do you want... So it's a lot of... Some places will do assess if they're at higher risk for preeclampsia, but not every place does. That's right. And so I think it's important that you send women to places who are confident and do good ultrasounds. Yeah, Sydney Ultrasound for Women's good. Yeah.
I think that the concept there is not a general radiologist, you know, that it needs to be someone who does obstetric scans and who
I report for INED, so I can vouch for them, but you're right. I mean, there's some general radiology practices, right, with this stuff. But I mean, to me, sitting on St. Women, office and care, INED, random women's imaging, I think there's a spectrum of.
Yeah.
In terms of the pre-cancer screening, I mean, there are some. I think you should probably have to request it.
Yeah, I think
there are some places that probably don't do it if you don't ask for it.
I think ultrasound care do it regardless.
Do they?
They do.
So, I mean, I think it should be something done.
Yeah.
To me, screening is something you should do in a low risk population. There are some women who should be put on aspirin based on the risk factors. So, you know, if you're really high to null etc. You should be on aspirin regardless of what the screening test shows. You should do a screening test, in my opinion, on someone who's high risk based on their risk factors.
Yeah.
So I'm not sure it should be done routinely on everyone, but I think the women who you think, based on their clinical history, are low risk, I think they're the ones who benefit from screening tests. It will pick up a handful of women who are high risk, where you wouldn't have otherwise predicted it.
Yeah. Like at some hospitals, they'll do it as a routine, like at RPA in there. Yeah. For every woman, they'll do it, but it varies.
So,
Yes. Yeah. They don't need to. Yeah.
And how should we advise people is that tricky, or is that
CMV is like a minefield.
It's a minefield.
I think it's probably, you know, the practical thing, I suppose, is just to make women aware that there's unknowns, I suppose, and being aware of trying to avoid being in contact with people with unknown febrile illnesses or undiagnosed rashes and things like that.
Yeah.
I mean,
the problem is a lot of CMV kids are asymptomatic. So I just tell my patients, you know, if you're whenever you're around small children, washing hands.
Yeah, that's good.
And I say to them, look, it's easy said and done when you look at a 2-year-old, but
Yeah.
you know, you do it, you have to reduce it. So
Yeah.
and I think it's much talking about people are conscious and
yeah.
changing nappies, that sort of thing. So yeah, I mean, it's difficult because it's not routine to test for it. Right?
That's right.
And if you do test for it, you know, what do you do?
What do you do with that?
And look, the problem I say, look, we can test you if your antibodies are all negative. That means you've got through 30 years of your life without actually seeing. But what are the odds you're going to get in the next few months? Probably not high, but do your best to avoid it. If you've got antibodies, well, it's probably some reassurance that you're not going to get a primary infection, and there's always the risk of reactivation. So I say people all the same advice, which is don't be slobbering on the small children. But it's difficult because, you know, there are women who have toddlers at home and
That's right.
In general
And they go to
practice, we
daycare.
worked through pregnancies, you know, with every second person with a febrile illness or a rash, you know.
Yeah, that's right. It's hard.
I mean, how many cases of CMV pregnancy have you all actually seen? I mean, I've had, I think, 2.
Like it's really, I don't think I've ever seen anyone.
Look, the MFM guys probably see it all the time, but you know, I'd see one a decade. I said, don't like that way of bringing out it, but wash your hands when you're around your kids.
Yeah.
Don't let them sip your drinks and that sort of thing.
Yeah.
It's difficult.
Yeah.
That's great, thank you.
So then in the follow-up appointment, you should have all the results from scans, blood tests. So if you can go through all of those, see how they're going, answer any questions, offer an early glucose tolerance test to people who might be at higher risk of gestational diabetes based on their ethnicity, other underlying conditions, strong family history of diabetes. And there's some information we're going to talk about that a bit more actually in a minute. And then talk to them about first trimester screening. So the nuchal translucency, either between 10 and 14 weeks for the NIPS and the structural scan. So they always need that structural scan as well. That's important. Not just the genetic test, the chromosomal test. And then you can do the nuchal translucency in the first trimester screening bloods between 11 and 13 weeks. And yeah, that's that. Consider the low dose aspirin based on that as well. that depends on where you get it done. So then, and that's, so it's then that you should do a referral to the women's hospital. There are a lot of referrals coming in really early because women want to get into the MGP, and then there's no bloods, there's no information, and then it doesn't get through and it's a bit of a mess and it's not really working well. So it will be much better if you hold back, and with that referral, you need to attach all of the results and information.
Have
Yeah.
you guys used
The-
HealthLink?
Yeah.
Southeast stuff?
Oh, yeah. Okay.
So if you, yeah. Yeah, so Consult Med's the peds to Sydney Children's.
Yeah, HealthLink's way better than Consult Med.
Yeah.
Consult Med.
HealthLink.
No. It's
at all. This self-populates.
it's
and
great.
It's set up. It's specifically set up for us. So we gave them the template that we wanted for it.
Yeah.
So you basically open HealthLink, click on Southeast Sydney area health local district, whatever that is now,
Yeah.
and then you go to antenatal care.
I think it's under women's health, and then there's a maternity care. Yeah.
It tells you it's got a second window down. So the first bit is the details. The second window on your left-hand side is where you put your attachments, and you can browse your files and pick up everything there.
Yeah. So it links in well with best practice. No, you don't need to do anything.
Anything, you just.
It just goes straight from best practice. It's so good. And it looks a bit like this.
The thing it came up in our meeting the other day that the midwives who are triaging the antenatal first appointments are getting patients before they've had their bloods or before they've had their first dating scan in the system, and then it's too early. A lot of those miscarry, so they allocate appointments.
Yeah.
It's really makes sense because there's a lot of pressure, right?
They're in.
They all want to get into midwifery.
We just have to tell them, I think,
Yeah.
that it won't be looked at this end without that stuff being there.
Yeah.
Yeah.
So just to put the brakes on, because they all ring midwife group practice.
Yeah.
And then the midwife group practice tells them, hurry up, go to your GP
Yeah.
and get referred so you can get in.
Yeah.
And so they all come in at 5 weeks, or they've just missed their period and they want that referral done so they're first in the queue. We just have to say to them that referral won't even be looked at until it's got these documents attached to it.
Yeah.
We're looking at the moment about having a kind of barrier line where it won't actually send until then,
I think that would be fair.
or
Yes.
or a reminder for us when we're doing it that unless that's attached.
So otherwise it's like
I know.
Yeah. And patients are very pushy. At our end
They are.
to get what
Yeah.
they want, and you're not very happy if they don't get what they want. So I think being able to say to them that it's actually something that's come from the Royal, that in fact the referrals aren't going to be looked at unless they've got the appropriate attachments to them, and when we get those things, we will make it happen ASAP.
Yeah.
Great. I've got one other question as well. Sort of subclinical hypothyroidism and pregnancy. But so I presume would we repeat it, and then would you suggest repeating it first? If it's wrong, then you retreat it in pregnancy. It's always a bit of a
There's
funny
good
thing.
There's good guidelines.
We'll talk about where you can find that sort of specific information
Yeah.
later on in the talk.
And it'll tell you the exact numbers and when to do what.
If in doubt, call the liaison midwives.
Yeah, okay.
Like the biggest thing I suppose that Anna and I can say from today is, if in doubt, ask.
Yeah.
Because that's what they're there for. They're there for those kind of things where you're not quite sure whether to jump or stay put, or you're not quite sure whether to do something or do nothing. Ask.
Yeah.
Is it treating it because it's associated with a high rate of miscarriage? Yeah, because it's very, it's always a bit difficult.
I don't think you
Explain.
I think it's. I mean, the first question is what TSH cutoff do you use, and something that you probably say, which means you're not diagnosed with women hypothyroidism. So Yeah, I think the evidence on it's a bit controversial.
Yeah.
I don't think it's a strong case for treating or not treating, to be honest.
Yeah.
I tend to treat if they've got antibodies.
Okay.
And I
Yeah.
don't know if they don't. There's some evidence that if you've got antibodies, it's like hyperthyroidism and probably more at risk of adverse outcomes, but probably it's a difference to probably routine to test to TSH.
No, that's right.
But the longest of criteria for testing is so long you may as well test it. They end up getting tested anyway, so it's easy.
That's right. They do.
Yeah, it's pretty debatable. There's not a hand of evidence that it's great.
Yeah.
But it is worth obviously reviewing your pre-existing thyroid
Of course,
disease
yeah,
patients and making sure that they're sitting in the zone.
Yeah, I just find it always really tricky because if you treat them and then something happens in the pregnancy.
Yeah, for sure. You did something, you changed something.
Yeah, so I find it's always a bit.
Yeah, no, there's,
Ask.
yeah, and there's good guidelines and it gives you the numbers and what to do and when to do antibodies and things. So, yeah, have a look at
Or
those.
if in doubt, refer them to the medical clinic. And you know, that's why all these systems are in place, I suppose, and because we are outliers.
Yes.
And although we are part of the system and we're working to the protocol, we can't be on top of everything. You know, we can't be complete experts on everything antenatal care at the Royal and everything orthopaedic care and everything, you know, paediatric care. So that's why these systems are in place for us to ask.
Yeah.
Yeah. So it's ideal if women are booked by 14 weeks but certainly if there is someone that you identify as high risk and needs a more urgent appointment, then if you call GP liaison midwife, and Wheeling's here now and she's here to answer your questions today too. So then again, around 14 weeks. So this is the time where you discuss the first trimester screening results. This is still before they've been seen at the Royal Hospital for Women. They might need some further testing. Do they need genetic counselling? Do they need a maternal fetal medicine referral? So if there are, so you can call the fetus phone, which I think is on your handout on the card. Yeah. Yeah. And certainly for things like if there's any fetal anomalies that are picked up, then that's what you do. If they've done an early OGTT, then you should have that by then. And then you can refer them for their morphology ultrasound around 18 to 20 weeks. The length of the cervix is something that needs to be reviewed at that ultrasound. And again, it's something that at certain places they weren't doing it routinely. It's something that you should specifically ask for and you need to look at because it needs to be more than 2.5. Yep. If it's not, then you'd refer into the hospital. So then they have their booking in visit. So they have their first visit with the midwife. So that's around 14 weeks. Takes about 90 minutes. So they do a full history as well, domestic violence, psychosocial screening and a risk assessment. So they'll go through a lot of information and education, and there's the yellow card that's given. So the yellow card is something that's really important to fill out at every single visit. So there's extra investigations that frequently are not being filled in by GPs, maybe not frequently, but it happens. So it's a card that is regularly updated. I know it's hard if women don't bring their card in, if you can just put maybe copies of investigations or extra things on there so that they can at least take those into the hospital, and reinforce to the woman that she should bring that card to every single appointment because it's going to get read and updated at every single appointment. Yes, that's it. Yeah.
I think nowadays, one of the things that we've sort of experienced, I suppose, is now often people go out just with their phone.
I know.
And they don't have a handbag, so they don't take.
Or a giant handbag that fits that thing.
So you know, the thing I suppose in the past was if somebody fainted in a shopping centre and somebody looked in their bag, it's clear that they were pregnant because they had this yellow card that had all about their pregnancy. That's not the case so much anymore. So just saying to people that how important that information is. And we were talking about, like, we are sort of starting to workshop, I suppose, solutions to that. But those, you know, the wheels of New South Wales Health turn slowly. So, you know, I was saying I'm trying to now get my patients, once I fill it out, to take a photo of it and have it on their phone. Just so once it's complete, each visit, take a photo of it, just have it on your phone. But I mean, you guys might find other ways of managing that with your patients. But people don't take a handbag and don't have, you know, this size yellow card. So just, yeah, it's a little bit of a current problem.
Yeah. Yeah. Nope.
Not yet.
Not yet. Or close.
That's on our wish.
Close. That's a wish list.
We
It's
like
not imminent.
them to entertain creating an app of some sort that we could, and then it could be a live document.
Yeah.
As I said, the wheels of New South Wales Health turn slowly. It took us long enough to get health pathways and e-referrals.
There's hope. So you'll get a notification if it's deemed that the woman is unsuitable for shared care, and then they might have an obstetrician review as well. So then when they come in to see you, there's just things that you have to do every single time. So a blood pressure every single time, check their weight, maybe a urinalysis, checking the fundal height, fetal heart rate with the Doppler. Do they have peripheral edema? And symptoms like headaches. How are they feeling once they start feeling fetal movements? How are they feeling plenty of movements? And then just to let them know where to go if certain things happen, which we'll talk about a bit more, and then just normal physiological changes in pregnancy that they might be experiencing. So a lot of women get a bit worried if they're not feeling the baby move. So just letting them know that there's a bit of a variation in that and that the movements aren't particularly obvious at the start maybe, but it'll get there. Then there's a 24-week visit. Again, there's going to be some changes to how these visits go. You're going to do that full assessment, do the blood pressure, weight, fundal height, baby's heart rate, peripheral edema, etc. You want to do some blood tests that they will give them a form for some blood tests that they're going to do between 26 and 28 weeks. So this is when everyone will do a glucose tolerance test. We do that second test for syphilis at this one, but then also their full blood count, blood group and antibody. Ferritin's not a bad one, particularly if it's been low, then you should be checking that. They can have the Boostrix. So anytime between 20 and 32, have they had a flu vaccine? Is it flu vaccine season? And then the birth unit. So they should, if they're getting anything like reduced fetal movements, if they're getting vaginal bleeding, cramping, then calling the birth unit. Again, 28 weeks is the next visit. So thinking more about the birth, how are they thinking they want the birth to go? What are their thoughts around that? Who's going to be there? Do all your normal assessments. Talk about the pathology results. Of course, anytime if their glucose tolerance test comes back positive or their iron's really low, then you need to contact them straight away for those kind of things. If their glucose tolerance test is positive, then you should contact the diabetic educator, and their number's on that sheet as well, to let them know, and they'll book them in. Discussing their mood is important at various stages. There's and doing the Edinburgh Depression Scale if necessary, but at least talking about how they're coping and what they're thinking and how things are going. Doing domestic violence screening, drug and alcohol screening is part of the Medicare requirements to claim 16591 for this visit. So making sure, I mean, it's important to do those anyway, but that's something that you need to claim under Medicare. Again, have they had their boostrix and flu vax yet? Are they booked in for antenatal classes and education? And again, when to call the birth unit if they're having symptoms. So at 32 weeks, again, you get another visit. So you do all your regular checks again. Maybe you repeat the full blood count and ferritin, particularly if their ferritin's been low. And again, have they had those vaccinations? And talking about fetal movements. Are they having plenty of movements? Where to go? Call the birth unit if they've got reduced fetal movements. So the last antenatal visit with us is at 38 weeks. Again, you do all the normal things. How are they feeling? How are they feeling about the birth? And then what's going to happen in that postnatal period? So that's things to talk about as well. And of course, things like breastfeeding. What are their plans for feeding the baby? Are they going to breastfeed, not breastfeed? Are they, who's around to support them? Have they done their vaccinations? They're going to come in and see you at 6 weeks. So just let them know about the vaccinations, the early childhood vaccinations at 6 weeks, and the baby checks that we do. And the woman gets a 6-week check as well. So you don't want them to book all of that in a 15-minute appointment. So there's 2 people involved, 2 separate appointments. So just make sure that they're clear on that as well. And that they can come in earlier anytime, of course, if they're having any issues. Again, that's things like flu vaccine. Yeah. It's yeah, that's fine. So it still gets checked at the hospital as well. Yeah. Do you want to start with postpartum stuff?
So then hopefully all is well, and the next time you see mother and bub might be at the 6-week postpartum visit. Sometimes you'll see them in the first few days particularly if there's breastfeeding issues, or you might have seen them for their first bout of mastitis already, or you might have seen them for, that it's not quite what they thought it was going to be and they're struggling. Particularly, we consider that not everybody has a lot of social support, and you may actually be having to be the chief advisor if people, particularly, around this area, there's a lot of people, English and Irish people who don't have a lot of family support, and you might be the only reliable bit of information they get. So, you may be actually doing a lot of stuff in that 6 weeks, but the 6 weeks is the formal review. So postpartum examination, assessing whether or not their lochia has ceased, whether the uterus is involuted, whether any sutures have healed, whether they've established breastfeeding or otherwise, being supportive of the individual's decisions around that. There's a lot of guilt for women about not breastfeeding or feeling like a failure if that hasn't happened. So we often have to support that. The Royal has a fantastic lactation service that we can refer into, and really encourage you to utilise that. They're really responsive, lots of advice to us on the end of the phone, but also really responsive to getting people in to help them. So a lot of people spend a lot of money on private lactation consultants who sometimes give really dodgy advice. Yeah. It's in all that documentation. The phone numbers are there. There's a voicemail service. So if they don't pick up, you just leave a message, they'll come back to you. And in my experience, they've come back within 24 hours. Some of them come back within hours. So that's great. And that's clearly if the patient's delivered at the Royal. So that's it. So at that
time you are looking at also doing an Edinburgh depression scale and just making sure that patients are okay from that point of view. Weight, BP, particularly blood pressure if the patient's had issues during pregnancy, checking wounds and stuff. If they haven't had a cervical screening test up to date at this point, this is a good opportunity to do that when you're doing PV exam. Looking at whether there might be other issues. So if there's been blood loss or things like that, you might want to check their iron status again, and looking for any outstanding results. You know, if there's patients who've had gestational diabetes, you may be wanting to do a follow-up glucose tolerance test to just see whether that is ongoing. Good opportunity to talk about contraception, and also pelvic floor exercises. So, you know, during that examination, having a look at whether or not there is laxity of the pelvic floor that needs to be addressed. Often people are just getting sensation back at that point, and you know, so a referral into physiotherapist. Again, the Royal has a great team of physiotherapists that you can refer into. And also setting patients' expectations. You know, I had somebody who recently presented with back and hip pain at 3 weeks postpartum because she'd gone back to running. So she hadn't really had any advice when she delivered. She was a private patient. She hadn't had any advice about the fact that she probably didn't have pelvic stability at that point, and she, you know, had injured herself. So talking to people about, you know, graduated return to exercise and realistic expectations about body image and stuff is often also important at that point. You know, people have social media idea, celebrity idea of walking out of hospital in their size 10 jeans. And, you know, we all kind of, most of us know that that's kind of not necessarily realistic. So just letting people readjust, I suppose, to what normal people do. Looking at any household contacts that should be vaccinated against pertussis as well. Anyone advising people that are coming into the household, if we can try and get a buffer zone around that baby. Well, I think it's a bit of a clinical judgment call, isn't it? So when we're doing this assessment, we're looking at their pelvic floor, we're looking at their rectus muscles, we're looking to see what their stability is like, looking at whether they've got, you know, glute wasting because they haven't been exercising. So looking at that posterior chain and seeing whether they're strong, seeing what they do, you know, if they're somebody who enjoys walking versus somebody who wants to sort of do a half marathon in 6 weeks' time, you know, the sort of doing that sort of assessment and using the physiotherapy department to guide them back to exercise. You know, I tend to suggest to people that, you know, you start with walking and then you start, and pushing a pram gives you a little bit of extra resistance, and then maybe, you know, looking at Pilates-based exercise, things like that, that look at getting that strength from the core up. But I think that's probably something you have to address on an individual basis with patients about what they like to do and what they're likely to do. So that's probably a bit individual. And also pointing people in the direction of the Raising Children Network. There's a great website, I suppose, and set of resources that's out there that can give people some really good running advice on being a new parent. And, you know, anyone who's taken home a baby brand new and been responsible for keeping it alive knows that first 6 weeks can be really stressful. So that's often a conversation I'll have at that 38-week visit as well, which is to just, I sort of comically sometimes say to people, you know, if you've had something to eat and a shower by the time it's getting dark again, that's been a good day, you know, and just sort of taking the expectation of having the Vogue living household and the, you know, gourmet meal set up kind of is probably unlikely to happen. But again, you know, people don't necessarily have a lot of help. And so also getting them a bit prepared for that time as well, with maybe stocking the freezer full of pre-prepared meals and things like that. Accepting help from people. If somebody wants to come and do a load of washing for you, let them. If people want to come and visit you, that's fine, as long as they bring food, that sort of thing. I haven't personally, but so the other thing we're doing at the 6-week visit, of course, is having a look at the baby. So important things, I suppose, are the baby's had a check in hospital, but it's sometimes not things, as you know, not always evident in the first couple of days of life. So making sure that you are thorough with that and have a really good look at the baby. Clearly, you're looking at growth, so making sure that the baby's putting on weight, and then establishing whether that is a problem with feeding or whether that's a problem inherently with something pathological going on with the baby. Looking at any things that morphology things that may be not have been picked up previously, and just being aware that every now and then something's going to fall through the cracks, and you might be the first person to notice the murmur or the slightly different facial morphology. Just be aware that those things are going to happen, and make sure that you're actually sort of being really thorough with that examination. Then obviously undertaking the first lot of immunisations. So that 6-week immunisations, talking to the patients as well about Bexsero, meningococcal B vaccination as well, which isn't yet part of the immunisation schedule, but we certainly recommend. Talking to people about SIDS risk, talking to them about linking in with parents groups and community. Early childhood centres will often have already set people up if they've made contact with that. But, again, the shyer, more isolated patients may not feel comfortable to do that. So sort of trying to help encourage them into those groups, and make sure that Blue Book's up to date, as well as updating the immunisation register. So going back to pregnancy now. So we've got our mum and bub. So we're just going to now touch on a few of the details of that we've touched on in the talk about the visits. What are we actually talking about in terms of those other points? So New South Wales Food Safety has is a great resource for foods in pregnancy. It's always one of the things that people ask when they are diagnosed with pregnancy, is what can I eat? You may have a patient who has a high BMI or a low BMI. Be aware there's a lot of recovering or recovered anorectics or people with eating disorders out in the community, and pregnancy can bring a lot of challenges with change of body. And so it may be important to have a dietitian and a psychologist involved in pregnancy for those people in particular, but, just making sure that you're watching for those sorts of things in pregnancy, and using the Royal Women's have dietitians. So if you need to get your patients into those services, again, all the numbers are in your little resource book, and you can refer in. If your patient has a BMI over 30, they're not going to be classed as suitable for antenatal shared care, GP shared care on the whole. So just to be kind of conscious of that, because obviously it's introducing a different set of risk factors. So just going over the things that may not be suitable for shared care. So you will occasionally refer somebody up and you'll get a note back to say, no, they've not been deemed as being appropriate for shared care. In the past, that communication hasn't always been great, but it's been a bit better of late. So sometimes, you know, you send a patient off and in the past you've not really heard much from them again. But now the system is much better with letting you know what's happened, that they've been deemed unsuitable or that there's been a problem. So BMI greater than 30, a patient with pre-existing diabetes, multiple pregnancies, complex psychosocial considerations. I think that's probably true, but it's probably a little bit individual as well. So I've had a couple of patients with really complex mental health problems, but I'm the one with the continuing relationship with it. So it's been decided that we would share care because that's actually been in the patient's best interest. So I think there's probably a little bit of give and take in that one, but obviously that's kind of one of the areas that may not. History of stillbirth, growth-restricted baby or preterm birth. For fairly obvious reasons, those patients are going to be monitored a little bit more closely and are going to be probably better in the hospital system. Risk factors for preterm birth, rhesus isoimmunisation. Fortunately, we don't, you know, I haven't seen much of that in recent times in local patients, sometimes in patients who are recently immigrant, but or complex infectious diseases or patients with epilepsy. So they will be held by the clinic and be triaged into the specialist clinics. So I think the real take-home message I would like you guys to have today is that if in doubt, ask. So don't feel that you have to solve everybody's problems. And if you are in doubt, refer them back or speak to the liaison midwives. I think the worst thing we can do for a patient is hold on to them or wait and see if you have any doubt. So if you've got any concerns, or even if you just want to run it past somebody, call the liaison midwife. You know, they're really experienced. They know the system back to front, and they're a really good source of running advice. They carry a mobile. They're pretty much they'll pick up pretty much straight away. Sometimes you might need to leave a message and they'll get back to you. But don't ever feel silly for asking. The only silly question is the one you don't ask. If you're not sure what to do, ask somebody. So the other reasons, obviously, now we start to get into some of the clear reasons for asking, and that is if you have somebody who has a positive oral glucose tolerance test, so they've developed gestational diabetes, they're going to be referred to the clinic. Identified intrauterine growth issues. Don't be tempted to alter your expectations of those measurements. So, you know, if the gestational age doesn't change. So, you know, if it's a few weeks out, it's out, and that needs to be followed up. So don't think that there's just, you know, standard deviations of error in measurement. You know, those things are really important. Development of antibodies, malpresentation or, you know, change of presentation. Any psychosocial concerns. You know, the Royal has a great mental health team, and patients can sometimes be identified early at that first visit and those systems be put in place. But as we all know, people respond to stress in different ways, and sometimes those issues arise throughout the pregnancy. People's circumstances change, people's relationships change, crises happen to people. So you can refer into the mental health services, and if they get any medical symptoms like a pruritus, or obviously, you know, if they've got other medical problems that evolve throughout the pregnancy, to refer them back in. Whoops. Why am I? Well, if they develop antibodies, if you're doing their blood group and antibody screen where they had no antibodies and now they do, they need to be sent back in. So when would you other times you would assess at the hospital. So if it's under 20 weeks and there's an issue with particularly bleeding in pregnancy or loss, the early pregnancy assessment service is there for those patients. That's a outpatients clinic. I think that would probably be an EPAS referral. So EPAS is a clinic that runs and they'll do ultrasounds, they'll do whatever needs to be done, and then they will arrange the definitive management of that patient or to follow them up. Again, that's a phone call referral or a e-referral, but it's in the gynae, I think, not the antenatal. So when you go on to HealthLink, it's not in the antenatal services, it's in the gynae services. So when you just to navigate your way through that, it's in a slightly different box. And again, any information that you can attach to that. So if you've already got the scan, if you've got blood group and antibodies screen, particularly, you know, those sorts of things, series beta HCGs. You can, but it's now an e-referral, and that's probably a better way of then being able to attach all those relevant documents. So if you've got beta HCG quant results and a scan, you can have that all sent up in the blood group. It just saves a lot of mucking around when the patient actually presents. So that's good. And obviously, if you've got a patient that is sick, or if it's after hours, emergency department. You know, clearly, you know, some of those patients with early pregnancy bleeding are going to be ectopics, and so straight to emergency with those. Any doubt? Over 20 weeks, the patient's assessed in the birth unit. So for any signs of preterm labour, abdominal pain, any bleeding, any suspected rupture of membranes, severe hypertension, that is a birth unit assessment. So the patient can ring the birth unit, you can ring the birth unit and send the patient up. There's also pregnancy day stay, and that might be for somebody with hyperemesis or needing a iron infusion, though that they're pretty hard to get and the protocols are a bit. I'm not sure what the hospital's preference is for that. I think probably not. I think.
It's really, I would say it's quite difficult because we follow very.
There's very strict protocols around iron infusions, such that I've got a patient at the moment with a ferritin of 5 who's an RPA patient, and that she doesn't meet the protocol for an iron infusion. They won't do it either because she's 20. What is she, 30? She's 36 weeks. They won't do it privately either. So she's going to go into delivery with a ferritin of 5. Hemoglobin's all right, but she's got nothing in reserve. I don't know whether that's.
Well, yeah, I don't know if the confidence to vary. Hemoglobin is still pretty okay.
Yeah.
It's not too fussy, but I don't know.
I mean, I would question what the indication is. I mean, there are people, I mean, I've got colleagues who give iron infusions to patients. I'm probably down the other extreme, but correct answer is probably somewhere in the middle. I mean,
Yeah.
There's no evidence that that iron infusions will prevent blood transfusion.
No.
You've said someone who is symptomatic of iron deficiency and can't stomach iron supplements or they don't absorb them. It's tricky. I mean, the problem is they're quite difficult to get here unless
Yeah,
you're
yeah.
profoundly anemic.
I kind of just have that sort of sense that we're going to have trouble the other side, but yeah, they've knocked her back at 36 weeks. Yeah. Mm. Yeah, I thought they did too. I'm not sure. I haven't had a chat. It was only yesterday, so I haven't had a chance to chase it up. But and obviously other things happen in pregnancy. So people, just because they're pregnant, can still break a leg, can still have an injury, can still have an illness, can still have pneumonia, can still have other intercurrent illnesses. So some of them are going to end up in emergency departments or urgent care. Urgent care is just not necessarily they're going to see somebody who's super experienced with pregnancy. So I tend to try and get my pregnant patients to go to ED just because they'll call somebody from the Royal if necessary. Urgent care, I've had a few people who've been given some interesting advice and prescribed things that they probably shouldn't have, that fortunately been picked up by pharmacy. But so bleeding in pregnancy, obviously we've done the rhesus status as part of the antenatal screening tests, and so you know their rhesus status. So the patients are going to need to have anti-D if they're rhesus negative at various stages in the pregnancy and if there's bleeding. So again, a reason for them to be seen in the ED after hours or through EPAS so that they can access that if appropriate. So looking at who's having problems. So just that understanding that in the early stages of the pregnancy, you should be looking for a rapid doubling of the quantitative beta-HCG. And if that's not happening, then you may have a pregnancy that's not viable or an anembryonic pregnancy. Or so looking at those sort of guidelines, checking with ultrasound the location of the pregnancy and the progression of the pregnancy. So, what part of that dating scan being at 7 weeks is that you can confirm that it's an intrauterine pregnancy and that it's got a fetal heart. And so you've kind of got one question answered already, that it's not an ectopic. So making sure that you are considering ectopic pregnancy in your patients who are bleeding. An EPAS clinic is there for those patients if we've got a question or a non-progressive pregnancy that needs active management. Sometimes nature will look after it for you, and patients who are prepared to wait and see, that's often the best way of managing it. But some people have difficulty with that and need to be referred into the clinic. Oops. Sorry. So 13 to 20 weeks again. Sorry. EPAS clinic or A&E if you need an urgent review, looking at cervical length and whether or not it's an ongoing viable pregnancy. If it's 20 weeks and over, no speculum exams, guys, no heroics from the general practitioner. They need to be here. They need to be seen here. And obviously there's other reasons why people might have some bleeding in pregnancy that aren't related to the pregnancy. But again, if you think that you might just have a look, probably not a great idea to have a look. Send them up here, please. Don't go doing heroic examinations if you've got any doubt. So the EPAS clinic runs Monday to Friday from 7:30 a.m. We've sort of touched on the fact that it's an e-referral. It needs an appointment, so people just can't turn up. The details are in your resource pack as well. It's a one-stop shop, as I said. They'll be assessed. They will be definitively diagnosed if possible, or plans will be made to follow them up appropriately if things aren't clear, and they'll be offered management. They are really good, and if they can, the patient will be managed on the same day. So it's a really fantastic service, and it's incredibly sensitive to women in distress. So we're very, very fortunate to have that. There's both medical and surgical management options, and that will be offered to the patients. And the communication is really good. You'll get a fax back the next morning to tell you what's happened, and sometimes a fax back that same day.
Just so we tell our patients, so say we get early, like the first trimester come up for non-viable pregnancy, and we send a referral to EPAS. Like, when should will we expect to hear back from EPAS? Because like they'll ask me like,
Yep.
oh,
They'll get a call.
But if you feel it's urgent, you can call the midwife in EPAS and let her know that, oh, I have referred this patient to you and have just sent an referral and this is soon. So at least you can let the woman know.
They're pretty prompt at getting back to people, really quick. Like, I would say, in my experience recently with e-referrals, if it hasn't been the same day, it's been first thing the next day, just depending on what time. Yeah. Yeah, it's really, really responsive. And as I said, if you're worried, or, recently I had one where the patient was really distressed and we just needed it definitively a clear answer and a clear plan. And I'd sent the e-referral, but I rang as well and just said, look, can you just pick her up quickly because she's not coping. So it's a really sensitive unit. I'm doing well here, aren't I? I keep bringing up. So one of the things that we're really lucky with is that all the sort of common things that you're going to strike, the hospital has a protocol for. And as long as you follow the protocol, you're not going to go too far wrong. So if you've got an abnormal glucose tolerance test, as soon as you find you've got an abnormal glucose tolerance test, you're going to be bringing that to somebody's attention. So to then ring and let liaison midwife know that the status of your patient has changed. She's no longer in that normal low-risk pregnancy category. She's now got to be coming into clinic. So she'll be seen by a multidisciplinary team then. She'll have diabetic educator involved, dietitian, physio, exercise. She'll be holistically managed. She'll have the physicians managing her in that team. And then her treatment will escalate as required. So, some of those patients are going to be dietary management. Some of those patients are going to end up on insulin, but they will be holistically managed in that team. So our job, I suppose, is to make sure that that glucose tolerance test is done early if it's a high-risk patient, and at the standard time for other patients. Also be aware, I suppose, I've just had it happen to me, a patient who'd had previous gestational diabetes in her first pregnancy. I sent her for her early glucose tolerance test, but she couldn't tolerate the glucose load and just lost it. So we just had to wait until the nausea had settled enough for her to be able to tolerate that to do it. So they're going to be watched a bit more closely, and they'll have a multidisciplinary team involvement. again, we've got a protocol. You don't have to rely on your memory. You don't have to keep all this stuff stacked in your brain. If you do, you're probably going to get it wrong, and the protocols might change and you might lose track. So it's a really good idea to just to check, and I'll go through that in a minute with you where you can go to find the really up-to-date if there's changes in protocols. So hypertension in pregnancy, you're going to have some patients who have pre-existing hypertension who will be identified early, but obviously our job as part of our routine antenatal check is to be checking blood pressure at every visit, and to make sure that you're doing it properly, using the appropriate size cuff for the patient so that you get an accurate measurement. Checking it a couple of times if it's outside of what you've been expecting, making sure that it's just not reacting to the fact that they've rushed to get there, or that, you know, something has given them a temporary rise in their blood pressure, and using a manual cuff to recheck it. Now, that may or may not always be, in general practice, something that's possible these days, because not everybody would have necessarily a manual cuff, but it's probably important that you have access to a manual cuff if you can. Again, if in doubt, refer them on. So if their blood pressure is outside the parameters to the pregnancy day stay unit, so they can be monitored. If they're symptomatic, or if their blood pressure is really through the roof, getting them seen straight away. And I think that's, again, one of those important things that, if in doubt, call. So the liaison midwife is a great resource for those patients who, you know, they're a little bit out of where you thought they were, but they're all right. Don't be tempted to sit on them if you're not sure. Make the phone call and check, or refer them into pregnancy day stay unit to be monitored if not. The hospital will then do what needs to be done, do the urine, do the CTG, do the ultrasound, and you know, it takes all that uncertainty and any risk away from the patient having bad outcomes, because you sort of were in the wait and see category. Just ask. If you're not sure, ask. Don't wait. Where am I? So thyroid disorders in pregnancy that we sort of touched on briefly earlier with Alex, about, you know, what's normal, what's not normal. So you're going to have patients who have a past history of thyroid disease, people who are known to be antibody positive, patients who are sort of morbidly obese, patients with autoimmune diseases, people who develop a goiter, or have a goiter that's been previously not noticed, patients who are on medications that might cause thyroid changes, although I presume that they would have been identified already and be probably in one of the medical management clinics. Be aware of your patients who've had fertility issues, or pregnancy losses, particularly recurrent pregnancy losses, that thyroid issues may be implicated there, so being aware of checking. People should ideally be taking some iodine, 150 micrograms throughout pregnancy. And if the patient has a known hypothyroidism, their thyroxine needs are going to be increased in pregnancy. So again, there's a protocol, a flow chart that's in your resources there that you can use as a guideline. Hyperemesis gravidarum. So nausea in pregnancy is a relatively common thing, and most of our patients will get away with fairly low-key management and dietary advice, and most people will muddle through. Sometimes people might need some antiemetic medication to help them through. But some of our patients are going to be in that other category, the patient who has true hyperemesis gravidarum, and there's a really good now protocol around managing that. And the New South Wales Health has a hyperemesis gravidarum policy to manage that. If you have your nausea and vomiting in pregnancy and you're not sure, MotherSafe has some great advice there, and you can ring for telephone support. Encouraging early booking at hospitals for patients who have hyperemesis gravidarum, and again, making it clear that the patient has symptoms when you're doing that booking form. If you have that e-referral form, if the patient's already symptomatic, making that clear. If you've already had to instigate some medication management, making that clear so that those patients can be earmarked maybe to be seen sooner rather than later. Sometimes you might have to, so part of that hyperemesis gravidarum assessment is quite notably called the puke score. And the puke score will delineate where your patient sits in terms of severity, and give you then which arm of the guidelines for management you're on, and whether they need to be referred. You might find that you're having to get your patients to back off some of their supplements in early pregnancy because it's making them nauseous or contributing to their nausea. Iron obviously is one of those things. You know, we've all probably had the patients that their first trimester of pregnancy is, you know, hot chips and crackers is basically what they're living on. And again, trying to advise patients about, you know, if they've got a good part of the day when they're not too bad, trying to make that their main meal, maybe not having to prepare the meals themselves so they don't have to smell the meal cooking and they are more likely to be able to eat it. Not letting themselves get really tired, not waiting till they're really nauseous and trying to eat small meals frequently, those sort of practical advice things that get people through. You might find that the patient gets some relief from some ginger or some peroxidine. Also thinking about whether they're constipated. It's common in pregnancy for patients to become constipated. That can contribute to nausea. If they've got reflux, obviously that's an issue that can contribute to nausea. So you may need to actually instigate medications for that. And there's some fact sheets for that through New South Wales Health. So you can go on if you're uncertain what you shouldn't do. There are some really good guidelines. Will I try and go there? Will I try and go there? Will I do it? Oh, where is it? Come and help me. There we go. Where are we? There it is. Yeah. So I've been waiting to take you here, and this is probably a good opportunity to do so. Oops. There we go. No. Yeah. So if you go onto the Royal website, there is a part for us, health professionals, and it has the clinical business rules. If in doubt, everything you need to know about pretty much everything is there. All the guidelines, all the links, all the pathways, the contact numbers, everything that may not be comprehensively in here or on your card is here. And it links to all the New South Wales Health guidelines, it links to the contact numbers, it links to management guidelines, everything. So if you need to know things like what you do if you have a patient with hypertension, if you have a patient with hyperemesis gravidarum. Here we go. If you've got a patient with herpes in pregnancy, if you've got a patient with hyperemesis gravidarum, nausea and vomiting in pregnancy, here we go. It's all there. We've got resources at our fingertips, and now, you know, with it all being online, you can come in here and it will tell you what are the guidelines, what are the New South Wales Health guidelines, and it basically spells out for you how to do the puke score, what those various stratifications in the puke score, at what point are you doing what? So is the patient going to be managed in the community? Does the patient need to be referred on? What is the recommendation in terms of medications? So those resources are there at our fingertips, and don't be shy. You know, the patients don't mind you pulling up a screen and checking. I think sometimes we feel that we should look like we know everything to our patients, but I think our patients are really reassured a lot of the time when we go and show them that we're actually using the current up-to-date resources at our fingertips. So don't be shy to go and look. If you can't remember what you should be doing, or it's not, you know, comprehensively covered in your booklets, it's all here, A to Z, everything you need to know, and more things you won't ever need to know are all there. But it's there at your fingertips, so don't be frightened to use it. So I'll go back to our PowerPoint. Oops, where am I? There we go. So where am I? How do I go to full screen? Sorry. You can see that I'm completely IT hopeless. Sorry, guys. So just basics, I suppose. We have GPs come in with various experience in obstetrics, and there's a certain understanding that you are here and you have taken an undertaking to be competent in obstetric clinical examination. And that's something that at this point we don't have a hurdle for you to jump. There's a level of, we assume, a bit of self-disclosure in this, that you've turned up here today because you are really interested in obstetric care. And if your clinical skills are wanting, that you will put your hand up and come and do some of the clinics that are available, or there's some after hours teaching available by some of our wonderful obstetricians that help support this program. So if you don't feel confident in your clinical skills, make sure that you avail yourselves of those. We were lacking them for a while during COVID, but they're back again now. So if you don't feel confident in your obstetric clinical skills, please come and have some time by the bedside and make sure you polish up on those skills, because these things are really important. Fundal height, position, really important that you are confident, and that the fundal height is the measurement from the symphysis pubis to the uterine fundus. So your confidence in locating the fundus and making that measurement, and knowing that it's a reproducible measurement, and that you are confident that when you measure that and you are seeing either advancement or that or stalling in that you can back yourself on that. So obviously that's the understanding that what you're measuring is not only the fetus, but the liquor, the placenta, the uterine wall, and obviously that's influenced by the mother's body. And in some patients, that's going to be harder to be sure of than others. Being confident in that. Making sure that the fetal size is where it's expected to be at this stage in the pregnancy. As I said, don't think about correcting dates if the fetal size isn't where you think it should be. It's a referral issue. So if the fundal height is outside what you're expecting for gestational age, 3 centimetres either way, ultrasound, get it measured accurately, have a look at the growth and well-being of the baby. Any concerns at all, refer them up. The system is here to support you, not to have you in isolation in your practice with a patient you're worried about. So if in doubt, call the liaison midwife, run it past her. She'll support you in your decisions about what to do and facilitate the next step if necessary. So anything, any concerns about fetal movements goes to the birth unit, so they can be properly assessed. Pregnancy day stay, we kind of touched on a little bit. So it's a call. So you have to make the call. It's not something where you refer the patient and give them the number. You need to call and speak to the midwives there about what the issue is. It might be hypertension, it might be hyperemesis, it might be an iron infusion. It's probably not going to be an iron infusion, but obviously blood pressure monitoring, they'll keep the patient in for a day, check their blood pressure through the course of the day, assess the patients who are at risk, patients who might need anticoagulation. They'll be taught, they'll be supported. The system is there, I suppose, to have that opportunity for patients that we're worried about to be looked at over time. So, that's probably the thing that we don't have. We can't have a patient sitting in our treatment room for a day while we go in and out and monitor their blood pressure and see whether it was just a few apparent measurements, but the day stay is set up to monitor those patients. And the phone number's there. So I think probably, as I said before, my biggest take home from this as new antenatal GP participants is, if in doubt, ask. If in doubt, call the liaison midwife. They are there specifically for this purpose. There was a time when we only had a liaison midwife a few days a week. We now have a liaison midwife full-time. So use that person. If not, of course, you can always call the registrars as well. The registrar on call. If you're not getting through and you're concerned about a patient, just as you would call the medical registrar if you had a patient with pneumonia and you wanted some advice, just as you would call the surgical registrar if you had a patient with abdominal pain and you wanted some advice. The birth unit for anyone over 20 weeks, and the patient has that number on their yellow card. The birth unit number is there. But you need to let them know that you're sending a patient there, or tell the patient that they need to ring in advance, not just show up unannounced. And obviously the switchboard at the Royal will page people for you if necessary. So as I said before, we've got a fantastic team, not only of midwives and obstetricians, but we have a multidisciplinary team in obstetrics at the Royal. We've got the physicians who are really involved, Sandra Lowe, Amanda Beach, Helen Barrett, who'll do all the medical management of your patients and are also a fantastic resource to call for advice on patients. Particularly, the thyroid thing is something that I often am ringing one of them for if patients fall kind of outside of something that fits neatly in the guidelines. Sume Lau for diabetes, fantastic. The genetic counsellors through the maternal fetal medicine unit, Deb Kennedy, really approachable. great service. We've got the Oasis Clinic for people who have sphincter injuries in delivery. We've got a fantastic physiotherapy department that's now really accessible. There was a time when it was hard to get patients in there, but it's now really a really working service. And they can drop in to classes. Obviously, for specific problems, you need to have an appointment and a referral in. We've got Mother Safe for drugs in pregnancy advice. There's social workers. There's a midwife who's dedicated to preterm birth prevention. And there's the fetus phone for any fetal anomalies or problems there with some of your early pregnancy diagnoses issues. In terms of the documents, as we've spoken about before, the yellow card, and just re-emphasising how important it is to get through to your patient, that is a living document for them throughout this pregnancy from beginning to end. Results, everything is on there, and it just means if they end up somewhere unexpectedly, everything people need to know is there. And until we get something better, just trying to encourage people to either have the physical document or a photo of it. Using the antenatal shared care guidelines, the laminated sheet as a shorthand, and obviously the bigger document has more detail, and using the website for more specific or more detailed information. There's the Safer Baby Bundle, which is a online learning module that you can do yourself. And there's also patient resources in there about all sorts of things and then, as I said, we've looked at the operating procedures and the clinical business rules that are there. So the other thing that's really important, and it's going to be really, really important in the next couple of months, is to be looking out for the newsletter that comes out from CESPN, which has updates. It's a quarterly email that'll come out to you from CESPN. The reason I say it's going to be really important in the next few months is, as we've touched on today, the shared care protocol is in a current state of being updated, and some of the timing around visits and the content of the visits is going to change and to what you've been told today. And you'll be notified that is imminent in a newsletter. And then at the moment, we're looking at maybe having a web-based update that everybody will come on board to go through, so that we can be confident that everybody has got that information. So just be aware that's imminent, I suppose. So it's antenatal education. As I said, there's tutorials on the antenatal wards with obstetricians. Obviously, that's a bit dependent on what's in hospital at the time and whether there's patients that are suitable for you to examine. But, you know, there's a lot of opportunity for you to get hands on bellies through clinics as well, and really, really encourage you to make sure that your clinical skills are up to date and that you feel confident. There's neonatal clinical placements as well, and I'm not sure how we access them. I think they were through, I'll have to check the access to those, and we try and bring that to you in the update this afternoon. But again, you know, if you're not confident with the examination of a newborn, a great opportunity again to refresh your clinical skills. In May and November every year, we have a clinical update. And we put a lot of time and effort into listening to the feedback from those meetings to garner what the subjects that we should cover are. Sometimes there's topical things that might happen. You know, obviously during COVID, we were doing, you know, a lot on COVID in pregnancy, and when things change in the outside world, we try and address those sorts of things. You know, when there's a general change in the management of something, or if there's a particular project going on through the Royal, we'll try and bring that to you so that you're really in the loop of what's currently going on at the business end of things here. So really encourage you to attend those. They're really valuable. And as I said, we put a lot of time and effort into the content and the speakers for those, and they're very GP targeted, very practical. And there's also online learning through CESPN and GP learning. The RAC GP website has a number of activities that relate to obstetrics. There is a requirement to stay active in the antenatal shared care program as a GP, that you fulfil a certain number of hours of education specific to obstetrics. And if you don't meet those requirements, then you'll drop off the list of people. The CESPN is fantastic at letting you know if you are getting close to the end of a traineum and you haven't ticked all the boxes. So, but if you're attending the updates, you will meet those requirements. The important other thing is that obviously this is what we do for a living, and there are some important things to remember about billing appropriately for your antenatal care. So an antenatal visit has an item number, and encourage you to use that, because obviously this is all part of data collection as well. So if you're not billing antenatal visit and you're billing them as time-based consults, just a 23 or a 36, then that data isn't being picked up by the Health Insurance Commission, you know, that, so you're contributing to that data collection. There's a birth planning appointment beyond 28 weeks. You have to have met certain criteria. You have to have done a mental health screening and screening for domestic violence and drug and alcohol. So you need to meet those requirements. You possibly may find sometimes that those billings get rejected because somebody else has claimed them. So I've found that sometimes they're being claimed in the clinic, and you go to claim it because you've done it, but it's not being paid. So, you know, if you need to have a look on Proda and see if it's already been billed by somebody else, you might find that. The postnatal consultation has an item number as well, but it has to be more than 20 minutes. So it's not a time-based consult. And it has to contain mental health screening and screening for domestic violence and drug and alcohol. Just something to be aware of in that visit is that, and in your antenatal visits as well, there sometimes are limited opportunities to get a woman alone, and that can be really, really important in the domestic violence space, and to be sensitive to the need to have a private conversation with the woman. No matter how supportive the partner might appear to be, you need to find a reason, a way to get the patient alone, to have that frank discussion with them about whether they are safe. And that includes the overly helpful mother-in-law that comes in with the patient to help, but in some cases is there to monitor and report back to the abuser what's taking place in the consultation and what's said. So that can sometimes be tricky, and sometimes you need to involve practice staff in that, with redirecting the partner, finding something for them to do, updating the baby's details or something like that. But it's really, really imperative that you have that time alone with the woman to be sure that she's safe. Right back at the beginning, the pregnancy test has an item number. Make sure you're including that. It's costing you to have buy the devices, so making sure that you have that. And the 4001 non-directive pregnancy counselling, you have to have done an online RACGP e-learning module to qualify for that, to have it attached to your provider number. It's not onerous. I think if it takes an hour, I think it's lucky. But we all do that. We're always counselling our patients about all sorts of things, but specifically about choices in pregnancies. It's something where there is a specific item number, and I'd encourage you to use that. It's there for a reason, to reward you for your care and your consideration and the work that you've done to prepare yourself for that. So look, I know it's been a bit of an information dump this morning, and some of it is common sense maybe to those who are kind of experienced, and some of it is a bit of a wash in your head. Some of it means a lot to you, and some of it is a lot of words and protocols that you haven't really had a chance to look at as yet. But are there any questions that particularly spring to mind? So if you look in your protocols, yeah, it's on the visit. Here we go. Second last page. But as I said, that is going to change in the next few months. It's currently being, of the booklet. Where am I? Sorry, you found it sooner than me. Yeah, it's not going to be drastic. It's going to be maybe a little bit about, at the moment, the Royal, in comparison to other shared care programs, has more visits, and that's going to just be rationalised a little bit to be more comparative to other services, but also just to economy of resources as well. So there's a little bit of a change in that to happen. And we were hoping that it would be actioned by now, and that this is when we'd be presenting it to you, but it's hit a little bit of a bottleneck, and we're not quite ready to roll it out to you yet. So that's why I think it's just really important to be aware of those newsletters that come, so that you can be up to date with what's happening. The presentation's being recorded. Sorry if you have to listen to me all over again, but yeah, on the CESPN, you can access it through CESPN. And we can send the slides through as well, if that's helpful. Yep. That's what they're there for, I suppose. They're there to try and identify people whose cultural practices require any specific intervention or response or consideration. I think, we have a very broad spectrum of patients who present to these hospitals, and the services are there to try and make sure that there is sensitivity to people's cultural needs. Specifically with First Nations people, we've got the Malabar Clinic that is specifically for First Nations care. That's the idea. The idea is to have somebody who's really across those specifics. Obviously there's availability of interpreters and stuff here if necessary. They can be booked for clinic visits, and you might need to do those for your antenatal visits as well. Alex, is there anything that you can think of that's, I mean, I know it's probably, you sit here and probably think that we're waffling on a bit about nothing, but.
It's actually nice to hear that the standard of antenatal care is kind of what we provide. You know, it's nice to, we're not doing anything outrageous. No, it was very comprehensive. Happy to answer questions. Like this, if you have got any clinical questions, happy to call me or text me anytime. I'll give you my number. So, it's easier to send a text than to wait on hold to a registrar.
Like a pretty mundane question, but I find just the routine MSUs a little bit frustrating because like so many women have epithelials and then asymptomatic pyuria with no growth, and you get them to it like the second or third time, and there's always epithelials and there's always pyuria and no growth. So what do you do? Just carry on?
If there's no growth.
Yeah, just okay.
If you get epithelial cells, it's probably a slightly contaminated sample. I mean, mixed growth I repeat.
Yeah.
And if it's no growth.
Okay. Next straight. Thanks.
I mean, the whole point is to pick up the asymptomatic bacteria areas that turn to higher.
Yeah. Or the proteinureas that haven't been picked up somewhere, you know.
Yeah.
Yeah.
I suppose the proteinureas
Unknown. Yeah.
Yeah, I mean, if there's no growth, there's a few months.
No.
New to this area, so for either the diabetes educators, statisticians, physios, they all have the numbers or emails rather than going to the health link.
Yeah, I think those are departmental, so they're through phone calls and yeah, they're not on the e-referral.
You can just send it. Yeah.
How soon do we expect to become?
We the diabetes educator will contact women as soon once we see they want to arrange for a session, new GDM session in diabetes educator, dietitian. It's usually every Thursday, 9:30 to 12. There's a session.
Anything else? No? Thanks a lot for your attendance today. It's really encouraging to see GPs wanting to be involved in the program. We're pretty passionate about it. Anna and I have been on the advisory committee for the last 3 years, and I was just saying earlier that I'm in the wonderful position. I had practice in Balmain for 25 years and then moved here 7 years ago to the east. So I was very involved with RPA, shared care, since 1992, I think I did my intake there. And I'm currently looking after the antenatal care of 2 patients whose mothers I looked after the antenatal care of. And that's really special, you know, it makes me feel really old, but it's a really privileged position. And you know, those relationships and the added benefit that you can bring as a GP when you know holistically patients and in the context of their families and stuff, it's a really special relationship, and it's great that you're wanting to be involved.
Is there actually a lot of demand?
Look, it's a really interesting thing. I don't know. I was just asking before what the numbers are like in terms of hospital presentations, because I know earlier this year we talked about at the advisory committee that there's been a drop in birth rate in this area for the first time in a very long time. And I think, you know, the reality is that the socioeconomic situation of people is different, you know, and cost of living crisis causes people to perhaps not have as many children, and certainly maybe not have more than one child and continue to live in the eastern suburbs or the southeastern suburbs. So I think, you know, there is a real interest in patients having their GP do their shared care for some. For others, they prefer midwife group practice. And as we said, you know, you've just got to resist that pressure to refer them in before their time. Some people prefer the traditional clinic setting. But I think the beauty of this is that we're able to offer people such a broad range of care. And, you know, we're very privileged to have those options, that there's just not one standard care that everybody has to slot into. You know, we're yeah. You would think so, but maybe not so much the assumed state of things nowadays. We were just talking before about menopause and how, you know, that really there's not a lot of people who are comfortable managing menopause. And if you get a bit of a name for being, you know, comfortable managing it, suddenly you're completely overwhelmed with patients wanting you to manage their menopause. You know, I think there's a bit of an ebb and flow. The other thing is you find that maybe sometimes clusters of patients will, so you have like one of a group of friends will come to do antenatal shared care, and then suddenly as each of their friendship group falls pregnant, they all come in to see you because they want you to manage their, yeah, you know, they all come and then the babies all come, and, you know, so it does ebb and flow a little bit. I've gone through this year with not a lot of antenatal shared care patients, and then suddenly I've got a lot again. So yeah, it does ebb and flow, but I agree. I think for me, you know, particularly, I suppose, not trying to be sexist, but being a female GP, I see it as core business, you know, to be competent in obstetrics. And it was one of my really specific things when I was thinking about general practice, was to go and do my DIPOBs and make sure that I had, you know, good obstetrics clinical skills, but it may not be for everybody. And I think the fact that we can offer people all these different pathways in obstetric services, we're blessed, and we're even more blessed in this area that our obstetric hospital is a tertiary referral hospital. So, you know, in terms of patients getting absolute gold standard, front of line, best practice care, we're so blessed. And their baby, you know, if it's got a problem, is going to be in the same place as them. It's not going to be having an ambulance ride to another hospital. Okay, guys, thank you so much for your patience. Thanks for coming. We're really grateful that you came to be our little backup.
As I said, if anyone's going to be clinical questions, 5 o'clock. My phone's always on.
Thank you.
Thanks.
Thank you.